Hello everyone and welcome to our module on ventricular pathology. The ventricles of the brain are four structures that contain the cerebrospinal fluid. There are two lateral ventricles and then a third and a fourth ventricle. And if you look at this image on the brain here, the ventricles are those black things in the middle of the brain. There's one on the left and one on the right. Those are the two lateral ventricles. And the ventricles in the brain are continuous with the central canal of the spinal cord so that CSF runs from the ventricles up in the brain all the way down to the bottom of the spinal cord. Here are some additional images of the ventricles. You've got the two lateral ventricles, which you can see here. The third ventricle sits in between the two lateral ventricles, and then it drains into a larger fourth ventricle, which is found near the brainstem. Let's talk briefly about cerebrospinal fluid. CSF is a clear, colorless fluid that fills the ventricles and fills the central canal of the spinal cord. It serves a couple of purposes. It provides some mechanical protection and is a shock absorber. It also circulates nutrients and removes waste. CSF is produced by ependymal cells of the choroid plexus. So ependymal cells are the epithelial cells that line the ventricles, and some of them will become specialized and form a structure in the ventricles called a choroid plexus, and this will secrete cerebrospinal fluid. CSF is absorbed by the arachnoid villi. So the villi are little finger-like extensions of the arachnoid layer, which is part of the meninges that surround the brain. And these little finger-like extensions, these villi, absorb the CSF, and from there it drains into the superior sagittal sinus, and then it goes on to drain into the venous system. Our first ventricular pathology that we'll discuss is hydrocephalus. Hydrocephalus refers to dilation of the ventricles due to excessive accumulation of cerebrospinal fluid. It's usually diagnosed by CT scan or sometimes MRI, and the hallmark finding is ventriculomegaly, which means enlargement of the ventricles. And in this image on the screen, these two ventricles are massively enlarged compared to the normal ventricles we saw at the beginning of this video. Hydrocephalus is broken down into two subtypes, communicating and non-communicating. In communicating hydrocephalus, cerebrospinal fluid is not being absorbed, and that's why it's building up in the ventricles. It's called communicating because the ventricles can communicate with one another. In other words, there's no obstruction to the flow of cerebrospinal fluid, there's just too much CSF. In non-communicating hydrocephalus, there's some blockage to flow through the ventricles, so the ventricles can't communicate with one another, and this will cause CSF to build up behind the obstruction to flow, and there will be less CSF beyond the obstruction to flow. We'll talk about non-communicating hydrocephalus first. This is a structural blockage of cerebrospinal fluid flow within the ventricles. This is often seen in babies because it's often congenital, and there are lots and lots of etiologies. But three that are worth knowing are aqueductal stenosis, Chiari malformations, and Dandy-Walker malformations, and we'll go through each of these in the next few slides. And on the screen here is an image of what a child looks like with hydrocephalus. Note that the ventricles are dilated, and the way this is going to present is that the head is going to be enlarging and the fontanelles are going to be bulging. Aqueductal stenosis is stenosis of the cerebral aqueduct, which leads to blocked drainage from the third to the fourth ventricle. If you look at this drawing on the screen, the third ventricle is found here between the two lateral ventricles, and it drains through this structure shown in red here, which is the cerebral aqueduct. From there, CSF fills the fourth ventricle, which is found near the brainstem. So when there is stenosis of the cerebral aqueduct, that will lead to buildup of CSF behind the stenosis, and therefore the third and lateral ventricles will become dilated. Aqueductal stenosis can occur as a congenital problem. This is usually an X-linked disorder seen more commonly in boys. It can also develop as a complication of inflammation due to intrauterine infection from some of the torch infections that are dangerous during pregnancy. These include rubella and CMV, and toxoplasmosis and syphilis. And the presentation, as I mentioned before, will be a baby with an enlarging head circumference and possibly bulging fontanelles. A Chiari 2 malformation is a congenital malformation of the cerebellum. In this disorder, there's downward displacement of the cerebellar tonsils, which are part of the cerebellum, and also the medulla in the brainstem. If you look at this image on the screen, on the left is what things should look like. On the right is what things can look like with a Chiari 2 malformation. The cerebellum is displaced downward, and this is going to block the flow of cerebrospinal fluid out of the brain and into the spinal canal. Usually the fourth ventricle is displaced by the malformation, and there's buildup of CSF behind the cerebellum, and this leads to enlargement of the lateral and third ventricles. And I talk about Chiari 2 malformations in more detail in the video on congenital neurology. In the video on congenital neurology, I talk about myelomeningoceles, which are a form of spina bifida. They're a form of neural tube defect. And in a myelomeningocele, there's a failure of the spine and meninges to close around the spinal cord, and as a result, the cord and the meninges can be outside the spine. And babies with a myelomeningocele are born with a defect on their lower back like this, and protruding out from the defect are meninges and spinal cord material. The reason I'm mentioning this in this video is because almost all cases of myelomeningocele also have a Chiari-2 malformation. And in babies born with a myelomeningocele, it's not just the spinal cord defect that causes the morbidity, it's also the hydrocephalus. Most of these children have major problems with hydrocephalus, and that's because there's obstruction of the fourth ventricular outflow. And I talk about this in greater detail in the video on congenital neurology. A Dandy-Walker malformation is another congenital malformation. This one involves the fourth ventricle. It's caused by underdevelopment of the cerebellum. Specifically, there's usually hypoplasia, which is underdevelopment, or agenesis, which is no development at all, of the cerebellar vermis, which is a portion of the cerebellum. If you look at this image on the screen, this is typical of a Dandy-Walker malformation. The cerebellum is very small here, and the fourth ventricle is massive. That's a Dandy-Walker malformation. There are also usually cysts that form in the fourth ventricle, and these can block CSF flow and cause hydrocephalus. Besides the malformation of the cerebellum and the fourth ventricle, there are many other associated symptoms and conditions that these children usually have. The main features of affected children are usually hydrocephalus, which presents as macrocephaly, delayed development, and also motor dysfunction. These children will have problems learning to crawl and learning to walk. Moving on, let's talk about communicating hydrocephalus. This occurs when there's some problem absorbing CSF by the arachnoid villi. CSF builds up in the ventricles and there's a rise in the intracranial pressure. And the hallmark on imaging is dilation of all the ventricles. In non-communicating hydrocephalus, some but not all of the ventricles will be dilated. In contrast, in communicating hydrocephalus, the lack of absorption of CSF causes CSF to fill all the ventricular structures. This can occur in adults as an acquired problem after meningitis. Meningitis is inflammation of the meninges, including the arachnoid layer, and it can scar those arachnoid villi, and then they don't absorb CSF normally, and that can lead to communicating hydrocephalus. Communicating hydrocephalus is also a classic complication of intraventricular hemorrhage, which is a problem that occurs in premature infants like this baby on the screen here. As the name implies, in intraventricular hemorrhage, these babies bleed into their ventricles, and that blood can lead to scarring of the arachnoid and therefore decreased CSF absorption, and that can cause communicating hydrocephalus. Next, let's talk about NPH, which is normal pressure hydrocephalus. In this disorder, there are enlarged ventricles on imaging like what's shown on the screen here, consistent with hydrocephalus. But when you perform a lumbar puncture, there's a normal opening pressure. That's why it's called normal pressure hydrocephalus. The pathophysiology is incompletely understood, but it's believed to be related to impaired absorption of cerebrospinal fluid. This is a disorder of older adults. Most patients are over 60 years old, and patients who develop NPH present with a classic triad of urinary incontinence, gait disturbance, and dementia, which most people remember by the mnemonic wet, wobbly, and wacky. The way NPH can be distinguished from other forms of dementia is by the findings of urinary incontinence and the abnormal gait. And the key finding in terms of gait is a slow, wide-based gait. It shares some resemblance with the gait of patients with Parkinson's disease, but unlike Parkinson's, NPH does not involve a resting tremor, masked facies, or bradykinesia, all the other usual elements of Parkinson's disease. The diagnosis is made by MRI, which is usually done when a patient has new onset dementia plus gait problems plus incontinence. The MRI will show ventriculomegaly like we saw in the last slide, but there will be no cortical atrophy. We'll talk in a minute about how cortical atrophy occurs in Alzheimer's and other forms of dementia, but not in NPH. And as I said, this is a potentially reversible form of dementia, and the way it can be treated is with something known as a ventriculoperitoneal shunt, or VP shunt. This is a catheter that's inserted into the ventricles in the brain, and it drains CSF into the peritoneum in the abdomen, and that can improve the symptoms of NPH in some patients with this disorder. The last topic for this video is hydrocephalus ex vacuo. This refers to ventricular enlargement that occurs with age or with cortical atrophy. And cortical atrophy is common in many forms of dementia, especially Alzheimer's, but also in Pick's disease and end-stage HIV. And what's happening in hydrocephalus ex vacuo is not that the ventricles are getting larger, it's that the brain is shrinking. This usually occurs after age 60, and what you will see on imaging is an increased size of the ventricles, but that increase will be in proportion to the increased size of the sulci. Let's look at this image of hydrocephalus ex vacuo at the top of the screen. So the ventricles are enlarged here, but note all these spaces in the cortex. Those are sulci, and they have become enlarged because of cortical atrophy. So the way you know this is hydrocephalus ex vacuo is that you don't only have enlargement of the ventricles, you also have enlargement of the sulci and cortical atrophy. In contrast, at the bottom of the screen is an image from a patient with hydrocephalus. The ventricles are enormous, but there's no enlargement of the sulci. And hydrocephalus ex vacuo is a common finding when you do imaging of the brains of older people, especially patients with dementia, and there's no specific treatment required. It's really just a finding on imaging. And that concludes our module on ventricular pathology.